Welcome to today's session. We're going to talk through lipids, statins, and cardiovascular risk, focusing on the latest NICE 2023 guidance and the AAC group updates. My goal here is to make this practical, professional, and easy to follow for daily clinical use. Let's start with who should be offered a statin without even calculating risk. Anyone with established cardiovascular disease should go straight onto atorvastatin 80 mg. In patients with chronic kidney disease, atorvastatin 20 mg is the starting point, and the dose can be titrated depending on renal function. For the very elderly, especially those over 85, NICE says there is no need to calculate Q risk. Age alone confers high risk, but the decision should be guided by frailty and tolerance. For most adults between 25 and 84 without CVD, CKD, or type 1 diabetes, QRIS-3 is the tool to use. If the 10-year risk is 10% or higher, then atorvastatin 20 mg is recommended. If the risk is less than 10%, statins can still be considered. Some groups are underestimated by Q-risk, such as people living with HIV, patients with lupus, those with severe mental illness, or people who have recently stopped smoking. In these situations, offering a statin can still be reasonable. In type 1 diabetes, the rules are different. All patients over 40, or those who have had diabetes for more than 10 years, or those with nephropathy, should be offered atorvastatin 20 mg. For younger adults aged 18 to 40, it can still be considered if other risk factors are present. Communication is key. NICE emphasizes that statins are cost-effective even below a 10% risk, but the decision must align with patient preference. QRISK-3 shows 10-year risk as a percentage, but you can also use QRISK-3 lifetime to demonstrate the impact of lifestyle changes, especially in younger patients. Showing the effect of quitting smoking, losing weight, or lowering blood pressure on lifetime risk makes the discussion much more tangible. Lifestyle advice should always accompany statin therapy. Smoking cessation is essential. Diet should be cardioprotective. Saturated fat, less than 7% of total energy, increased use of olive or rapeseed oil, whole grains, plenty of fruit and vegetables, and at least 2 portions of fish a week, with one being oily fish. Alcohol should be kept under 14 units a week, spread across several days. Physical activity should be 150 minutes of moderate exercise or 75 minutes of vigorous exercise weekly, along with strengthening activities twice a week. And weight management services should be offered where appropriate, especially given the link between obesity and cardiovascular risk. Once a statin is started, monitoring should be practical and not excessive. Begin with a baseline lipid profile, renal function, and a LT or a ST. A fasting sample is not needed. Only check creatine kinase if there are unexplained muscle symptoms. At 3 months, repeat the lipid profile and liver enzymes. At 12 months, repeat liver enzymes once more. Then no further routine testing is required unless symptoms develop. Annual reviews should focus on adherence, lifestyle, and whether the patient is on a high-intensity statin. Treatment goals are clear. In primary prevention, aim for more than a 40% reduction in non-HDL cholesterol. In secondary prevention, aim for LDL at or below 2 mmol per liter, or non-HDL at or below 2.6 mmol per liter. If targets are not reached, review adherence and timing of doses, and consider increasing the dose or switching to a higher intensity statin. So what happens if statins are not enough or not tolerated? The first alternative is ezetimibe. It can be used if statins are contraindicated, if there is genuine intolerance, or if targets are not reached despite maximum tolerated doses. It can also be added in secondary prevention, even when cholesterol targets are already met, to further reduce risk. PCSK9 inhibitors such as evolocumab or alirocumab are reserved for very high-risk patients with cardiovascular disease who remain uncontrolled despite optimal therapy, and only if NICE criteria are met. Inclisiran is another option in some cases. For patients with high triglycerides, icosapent ethyl can be considered in secondary prevention when levels remain above 1.7 mmol per liter. Now, the topic that generates the most discussion: side effects. Muscle symptoms are the main concern, but it is important not to label someone as statin intolerant too quickly. NICE advises a structured approach with de-challenge and re-challenge. If CK is normal and symptoms are tolerable, continue the statin. If CK is modestly raised or symptoms are severe, stop the statin for 4 to 6 weeks. Once symptoms settle, reintroduce at a lower dose or switch to a different statin. If daily dosing is difficult, alternate day or twice weekly atorvastatin or rosuvastatin can still be effective thanks to their long half-lives. If multiple statins have failed, then ezetimibe, bempedoic acid, or PCSK9 inhibitors are options. For very high CK levels, more than 50 times the upper limit, suspect rhabdomyolysis, admit the patient, and stop the statin immediately. After stabilization, other therapies may be needed. The overall message is simple. Statins remain the foundation of cardiovascular prevention. Use Curis 3 appropriately, recognize the groups who are high risk by definition, combine therapy with lifestyle change, and monitor sensibly without over-testing. Don't abandon treatment too quickly if side effects occur, and remember that even low doses can meaningfully reduce cardiovascular risk. That brings us to the end of this session. Thank you for joining me. I hope this has clarified the latest NICE guidance on lipids and statins and made it easier to translate into day-to-day practice.